So this is really interesting. I'm going to start with the last question there about the implementation. And a minority voted for the outer setting. So only 29% said that factors from the outer setting would be that relevant when you're looking at implementation. So this morning I said that we were going to look at the macro influences this afternoon, and it's interesting because if you were to look at, if you were to ask this question in England about the outer setting, then this would be a big factor in terms of what impacts what they implement in the hospital setting. And we're just going to show you a little bit of why and how that has worked. So I've got a question mark there, tools for change, because I think everything that we've said today has been largely about focusing on the individual, focusing on groups, focusing, within the organization. The theory tells us that we should try and not have external, top-down, coercive forces. This is what the theory tells us and the practice. However, in England, we've diverged from that. We've diverged from our European partners, essentially, in how we've done things in infection prevention control, where we have used external auditing. There was the question this morning, external feedback, publicly available indicators. All the indicators around healthcare-associated infections are in the public domain by hospital and now by GP. So by general practice, the use of antibiotics, broad spectrum versus narrow, etc., it's all now in the public domain. So we are moving more and more towards more information in the public domain. So there is a big macro influence when it comes to the English context. And that's something that's interesting to observe. So I'm going to be touching upon that in the next few minutes. So one of the things we set out to do with Gabrielle leading on this work was to look at how have we approached this macro sort of level of influence in 3 countries, and we looked at England, France, and Germany. And this is a paper I would ask you to have a look at. This morning I said don't bother, but this one I would say do have a look, because it hopefully will be very relevant to you operating in France, and also having a look at your neighbours to see how we have done things differently and why we have done things differently. And I hope that that will be a helpful piece of a resource. So when we looked at this issue, we looked at that top level, the macro level influence. But obviously, when something happens at that macro level, whether it's economic or regulatory, or there's the epidemiology, which is demanding you to do something, then it's going to have an impact on the organization, directly or indirectly. And then, of course, it will indirectly or directly have an impact on what you do as individuals and how that may or may not shape your behaviors. So it is in the CIFA framework, the outer context, and it's an important part of any analysis that you do, really. So when you're looking at implementation at the organizational level, there are key drivers in the macro context which may either help you because there is an influence saying this needs to be done, or there may be something else that is maybe acting as a barrier. So it's worth having a look at that. So just to tell you in terms of what did we ask in the question that we did in this paper, this study, what we wanted to know was when we're looking at infection prevention and control and antimicrobial stewardship in these 3 countries, are they doing things different across those countries? So it was a comparison. But also what we wanted to know was, are they doing things differently from other parts in the health system? So is IPC and AMS being treated special for any good or bad reason in the way it's being governed? So the governance around that. So when we talk about governance, we are talking about who and how of priority setting. How do you set priorities in IPC and AMS? How do you monitor performance and who is monitoring that performance and who is held to account and who is holding people to account. So who are the actors that are holding the health professionals, the organizations to account? So those are the questions we asked. And it would be really interesting to reflect in your, with your peers, perhaps who are not here today, what do you think is the situation in France? Who is setting the priorities? How is performance measured? And who are you accountable to? Are you accountable to the patient because you put them as first in your, in your poll just now? You put them as the majority for what is this about? The taxpayer. Are you accountable to them, or are you accountable to somebody or something else? So these are important questions, not just for IPC and AMS, but for a health system, and it will depend on what kind of health system structure you have. So I'm only going to briefly touch on the findings because it is a detailed analysis that we did, and there is no there's no sort of continuum or taxonomy that we can give you and say, you need to be at this end or the other end. It's got to be context specific, but hopefully it will help in how you look at how you do things in France. So just to give you a summary, what we can tell you that is in England was the outlier or divergent or different to the other two countries in the level of regulative interventions around IPC and AMS, and the governance structures were not that different to how the rest of the NHS in England is set up, because it is quite top-down. It's not decentralised. So in that sense, it was in keeping with how the NHS in England works. So France seems to have moved away from the top-down authoritative approach to a sort of a softer and mixed model of governance, which is in keeping with everything that we've been saying today, really. But what you haven't done, which would be in keeping with that, is have the information for the public to see what is really happening. So, and there are reasons for that, why you have gone down a certain way, and what the plans are for the future. We'll be interested to hear from you today, what is happening in that direction. But Germany was the most devolved and decentralized, because you'd expect that, wouldn't you, because of the way their health system is set up. But it's interesting that they haven't done anything very different in IPC and AMS. It's in keeping with their health system. So out of the three, I would say that England has been more centralized than the rest of the health system when it comes to IPC and AMS. So even by the standards of the national health system, it's been really centralized, top-down driven. Does anybody know why that has been the case for IPC? Why have we been subject to so much actually regulation and interventions from outside? Any ideas? Okay, I'm going to move on. Well, if you think about it, it's not so different. This is the kind of data that's available to the public about all sorts of health outcomes and indicators in England. So if you look at that list, there's data on diabetes, there's data on obesity, and AMR, local indicators, are just one of a set of indicators. So you could just say it's just a natural progression. Because AMR and IPC is a problem, then the public need to know about it, and there's this external influence as a result of it. So it could be a very natural thing. This is what it looks like if you go on this toolkit, and I would encourage you to go and have a look if you haven't. It's called Fingertips. If you can just Google that, Fingertips Public Health England, you can go and find out the data for hospitals and now, as I said, GP practices, to look at their different rates, their usage of antibiotics, their health-associated infections, and lots of other indicators as well. Do you think the public in England look at this data, the patients? Do you think they go and look at it? Put your hands up if you think the average patient will go and look at this information. If you think yes. There's no voting, so just put your hand up if you think yes. So put your hand up if you think nobody would use this much. Yeah, so the majority think that people don't use this. Okay. Okay, so you're right, most people don't use it, but when you present them with the information, so if you present them with this information in a room like this, they are able to engage with the information really well. So they are used to seeing this kind of information, and they are able to make some decisions based on this information. So you probably can't see what everything is there. So what I'm going to do is just quickly just read what's on that side of the column. You've got MRSA rates as the first indicator. You've got readmission rates as the second one. You've got the inpatient survey meeting physical needs of patients in a hospital. You've got overall experience, which is called the friends and family test. The question asked of patients is, would you recommend this hospital to your friend or family? This is the survey in England. And the last one is about staff. How satisfied are the staff that work in that hospital? Okay. So the red, amber, green obviously is red means worse than expected. Green means better than expected. And the orange, amber is, you know, it's almost, it's not looking good, but it's not as bad as red. Okay. So if you were a patient, which hospital would you want to go to? So if you would like to go to hospital A, put your hand up now. We have one patient. We are not going to be busy in this hospital. Okay. If you would like to go to hospital B, yep. Okay, most of you, a lot of you. Anybody would like to go to hospital C? Nobody. Okay, good. So you have voted like the public voted. So you are specialists, and you have inside information, and you voted for exactly the same as the patients voted. But what is interesting for us was that when we said to people, rank them, so put them in order, you have to go, which one? So which one came last? A? Put your hand up if you think A was the last one they would go to. You think so? Few people. Put your hand up if you think C is the last one they go to. Yeah. More. Yeah. Okay. You're right. So the one that they really didn't want to go to was C. And the reason they didn't want to go to C was because they said if the staff are not happy at this hospital, there is a big problem. They also said that hospital A, although it has a red on the MRSA rates, they said this is something that can happen. And what they wanted to know was this an upward trend? Is this a peak? Or is it a downward trend? So they were very sophisticated in how they were handling this information. Now, the reason behind this is because they have been exposed to this kind of information for a long time. So they see this information. So if they see a red on MRSA rates, they're not going to go running and saying, you know, I cannot go to this hospital. They've not come to accept it, but they understand it can happen, and they would want to have more information. So how is this helpful to hospital staff? So some hospitals in England, they have this kind of rating on their wards or units. So they will use this system to show them, you know, different indicators, so hand hygiene, uptake, or, you know, we haven't had an infection here for a year, X months, etc. So when you provide people with information, they feel more comfortable, because even if it's bad news, like Trust A, they would like to know. They would rather know. So this is interesting very much from the NHS perspective. Okay, so the question is, has that information and that lot of information in the public domain, has that translated to policy? And this is a paper led by Enrique that we worked on to look at how do European policies, where do they place the patient and the public in their policies? And what we found was that mainly the role is about convincing or expecting patients to not ask for antibiotics. So that kind of seemed to be the biggest role, which seemed very narrow. And in terms of behaviors, as Enrique talked about, it's asking people not to ask something of the health system. It was also the negative behavior in terms of trying to motivate or explain. So in the policy domain, we haven't really caught up with that. Okay, so if we now look at another country, if we look at Japan and England, and the reason we looked at Japan and England is because we're looking at two high-income countries with two very different cultures, because we talked about culture, didn't we, earlier, and we said how that might be important, but we're looking at national cultures and how they do things. Again, I would encourage you to read this one, because this is very specific to your area, and also it shows you what is happening in terms of MRSA rates in Japan, where they have gone down, but they are much higher than in England. But their data is based on a very small sample of hospitals, because they are still using voluntary reporting of a small subset of hospitals. So they don't have all the data. If anybody is familiar with how Japanese firms, industry, other than healthcare works, their philosophy is about quality improvement, very much bottom up. So no top-down interventions. It's very much about quality improvement, being lined up with the mission of a company, wanting to improve because it's the right thing to do for the companies. And that the right thing might be because it's for the viability, the financial viability of the company or the reputation. So there's lots of different reasons. Seems like there's a similar approach to healthcare as well. So it will be interesting to see how that is managed. The other reason we looked at Japan was because we have an aging population, our demographic shift in terms of how the population is moving in England. And it's useful to see what Japan is doing because they are ahead of us in terms of their aging population. So there's lessons to be learnt from there, and especially in terms of how they've organized social care as well. So just to say how you can look at the macro level, and you may find other countries which may be comparable to France from your perspective because of the way they are doing things. So it was just to let you know about that, some cases there. So back to England again. When we had a look between 2000 and 2015, there were no less than 869 national interventions, national level, macro level interventions in infection prevention and control. So that means a guideline, a recommendation, from centrally driven. 70% of those had a regulative component. So when we're talking about governance and accountability, 70% of those were regulative in some way. And you may be thinking, why? Okay. So this picture may be familiar to some of you. This is MRSA rates from that year. So this the year of the study, 2000 to 2015. And this is the data just up to before 2015. And this is 9 trusts, so that's 30 hospitals in England. And you can see the intervention there, introduced in 2005, which was the national target set for MRSA rates to be improved year on year. So they were monitoring them, feedback back to the local health authorities. And if you weren't improving, you would have a team come in to come and help you improve and try and work out why it was that you were not able to. So you remember I mentioned the 170,000 euros. So it was because they had this data. So if a hospital had improved, even though they weren't the best, if they had made a really good improvement in the year prior, they were one of those hospitals that were given that money to help them carry on. So we had the data, essentially. So in your answers, when you said, when you're considering an intervention, you put down HCAI rates as being important. So you put patient needs first. Sorry, you put patient needs first, and you put national guidelines second, and then you put HCAI rates third. Okay. So what do you think happened in England when the HCAI rates were at their highest? What do you think was happening in terms of practice? What were people doing? Let's have you speak. Some comments. What do you think was happening? Anybody? Yeah, they were doing bad, but what do you think they started to do when they were presented with this data? Yeah, they started to implement a lot of the interventions. So we could argue that, well, actually, if you externally audit, and I'm only arguing, I'm not saying this is the case, you could argue that if you externally audit and you feedback these results externally and you come in and help if somebody can't sort it out, then look what the evidence tells us. Okay, what's the problem with this approach, though? Is there a problem? Maybe there's no problem. Maybe this is what everybody needs to do. What's the problem with this approach, do you think? Any issues? They're becoming perfect? You think they're lying? Okay. Okay. We're very honest people. Everybody was very honest. Let's assume they're very honest. Then what could still be the issue?
They stop the program to...
They stop the program. So when they start to improve, they think, is that what you're saying? Is that what's being said? Yeah. So as things get better, they think they've solved the problem. Okay. Yeah. And also, as the rates get lower and lower, how much can they improve year on year? Because the targets were, you have to reduce by 50% or 25% every year. And then they're saying, well, we're hitting a plateau. So what happened in England? It became zero MRSA. So it was zero tolerance was what is the phrase, not was. It is the phrase. So if you even get one, you have to have what's called a post-infection review. You have to analyze what happened and you have to report it. This is where we are in England. Yeah, exactly. So. But, there would be people in policy and government who would say, yes, this works, because look at this graph. Okay, so the problem is, as you say, you may stop, but also, what about the other infections? Because here, I've shown you a very selective graph, haven't I? To show you, yes, Minister, this is all working really well, but what about the rest of it? Okay. So when you're focusing just on one or two infections, you're blinkered like a horse. You don't know what else is going on. This is not to say that this happened because they were only focusing on MRSA and C. difficile. It's because what they had assumed was, by focusing on MRSA, giving that feedback, that people would change their practice across the board. If everybody is washing their hands and everybody's implementing the right interventions, then this should have an impact on most HCAIs. So it seemed that this was not the case, that it didn't change IPC practice universally so that we were better at IPC necessarily. There were some really good examples where that did happen, so we're not saying it didn't happen at all. There were some very good hospitals that changed the way they operated through system design and many other ways that meant they were actually better at IPC. But it's an interesting concept. So it's just to say that when you're looking at this work, which was primarily when we were looking at the organizational level, it's really important to go one level up and look at what's happening in the macro level. And what we wanted to do was just stop there and give you 5 minutes to answer that last question, if that's okay. Because you've been exposed to lots of different ideas and theories and all sorts of things, and maybe looking at the international level. But we did want to ask you what you thought were the main barriers to implementation. And we'd like you, please, if you could spend 5 minutes, because we still have till 4 o'clock, and it's 5 to now, to write those down. Can we just get that slide up, please? Thank you.
Je vais en prendre 5, d'accord? Puis après, on fera la synthèse et on vous l'enverra. Enfin, on vous la restituera. J'en prends 5 au hasard. Peut-être certains d'entre vous vont se reconnaître. Alors, prenons les freins. Alors, premier frein, manque de moyens ou de temps, lack of time and resources. La politique de l'établissement, so political issue in setting. Le turnover important et l'absentéisme, turnover of staff and shortage. Je n'arrive pas à lire, je passe. Le manque de cohésion, collaboration entre médicaux et paramédicaux, lack of cohesion between nurses and doctors. Aujourd'hui, tous les sujets sont prioritaires. Les cadres de santé ne savent plus où donner de la tête. So everything is a priority, we don't know where to go. Méconnaissance de la part des équipes soignantes, des équipes transversales. Exemple EOH. So people don't know who is the infection control. Yeah. Yes, already said.
So thank you so much for filling those out. Some of these barriers and facilitators are interesting. What we will do is, obviously they are in French, so we will have them in French and in English, along with the multiple choice voting for all of the sessions, and we will have a summary so everybody gets everybody here gets that along with the slides and the recording. Is that helpful, perhaps? Yeah. And then we can then map it to the CIFA framework to see where you all think we will map them, because we will be able to see whether they sit mainly in the outer, inner, or the intervention or individual. And some of them will be in more than one, but that's how we would feed that back to you. So we will do that work. Yeah.
Donc oui, enfin, vous avez compris, vous avez eu la traduction, je pense. Donc on vous donnera un feedback de tout ça. Juste en 2 mots, des leviers, parce que vous avez eu les barrières. Donc l'ancienneté dans le service, notamment à l'EOH, l'expérience, la présence de référents en hygiène dans les services, penser aux patients, la présence sur le terrain de professionnels montrant les bonnes pratiques, donc les correspondants en gros, écoute et acceptation quand il y a des problèmes qui surviennent, notamment lors d'épidémies ou d'infections associées graves. Le soutien institutionnel, l'ARS par exemple, effectivement c'est l'autorité de santé. Un autre et un dernier, et puis on arrête là. Donc la motivation de manière générale, l'empathie et l'écoute, les connaissances et le soutien de l'encadrement proche. Bon, c'est des choses qu'on connaît tous. Je pense qu'à l'échelle globale, sur l'ensemble de vos remarques, on pourra avoir quelque chose de clair. Et effectivement, comme le disait Raheelah, on va analyser en fonction de tous les modèles que vous avez vus ce matin, et puis on vous les restituera.